Okay, if I'm continuing not to be there, you get to see the beginnings or complete another video. So I'm going to talk about experimental studies, or often called interventional studies. So this is the type of study where we actually get to assess causality. So one of the big differences here is that you're applying an intervention and determining the effect of that intervention on some meaningful outcome, such as pain or function or strength. These are typically called randomized clinical trials or randomized controlled trials. And you, as the investigator or part of the investigative team, actually are assigning subjects randomly, keyword there, randomly, to one of two groups. So you don't have any control over that. A quasi-experimental design is where you say, okay, you can be in this group and because of this, and you can be in the other group. So it's not a true experimental design unless it's a randomly assigned, and that's a really important prospect of procedures that have to follow as you develop that random assignment. How you organize that, who generates that random sampling of information is really important. So characteristics of RCTs is that you're going to compare outcomes of participants assigned into one of two conditions. You can have more than two conditions. You can have 3, 4, multiple cohorts or multiple groups, but you just have to be really careful that you have enough numbers of subjects and have enough support to manage all these different groups. But the goal here is to answer the question is, does the intervention affect the outcome differently in one group compared to the other group, whether it's a standard of care group or a relative control / placebo group? Is the intervention more effective? And Dr. Fleischer talked a lot about if you're doing benefit or if you're trying to reduce harm. And in the book it talks about superiority studies or inferiority studies, that it might be more cost effective and you get the exact same outcome. So you might be looking for something where it's equally as effective but not as expensive intervention. So what are the characteristics you're thinking about? So obviously you have an interest in an intervention. You got to think about how long that intervention is going to take. How do I evenly spend time or apply some other activity with the control group so that you have a balance? If you have patients doing nothing and the other group is getting massage and stretching and a lot of one-on-one time, you're introducing bias into that relative intervention study. So there's factors beyond just the intervention itself that have to be considered so that you're equating the volume of activity with that person. Obviously, you're going to have inclusion and exclusion criteria. You can get really specific on exclusion criteria and try to get a really very controlled study, and sometimes this diminishes the external validity of that. It makes it a very clean study, but it's not really representative of a typical patient population that might be who you would want this treatment to go for. And I think that's the difference between efficacy and effectiveness. Efficacy is more controlled clinical trial. Effectiveness is a little less control, more real life, if you will. You're going to have to decide on what your outcome measurement of interest is and how big an effect you're going to need to see, which is really going to drive the number of subjects in your study. And Dr. Bush is going to come in and talk a little bit about sample size estimates, but understanding the effect that you're having or the change scores is really important to help you identify how big this study is going to need to be. Obviously, a small effect size, you need a large number of subjects to see a meaningful change. The larger the effect, usually the less number of subjects. What's the appropriate comparison? I've sort of alluded to. It's really tough if you're doing an intervention where you're communicating with them, you're doing speech therapy with them, you're doing occupational therapy with them for 30 or 40 minutes. What are you going to do in the other group? What is the equal but opposite, or not opposite, but comparable group? And then now, if you're doing an intervention study and you're doing it in therapy, what's the appropriate level of blinding for the participants? How do they feel like they're still getting care versus how much are the researchers biasing the outcome results? So that's really important to take into consideration. How can I minimize any bias? Are there procedures I can follow to help reduce that? I'm happy to talk about that and answer some questions related to that. And then how are you going to randomize? The method of randomization, it's not hard to randomize, but there are different procedures that you need to think about that. The website that I use is randomization.com. It's a really nice, simple resource. You can put in the variables that you want to randomize, and then you can do it all in one. So I want 50 subjects, and I want randomized 2 groups of 25. Boom. But the concern often is when you do it that way is you're getting a lot of you might have to wait a long time before you actually get an even sample. So sometimes it's more advantageous to do block randomization. So if I want to do blocks of 6 for 2 groups, that would mean that every 6 participants I would have 3 in the intervention and 3 in the control, and I might go up to 24 or 30 subjects or 60 subjects, but I'm evenly getting randomly assigned controls and experimental every 6, so I can do some preliminary analysis to see if there's anything going on with my data. I might not do it, but I might have a statistician who's blinded and keeps me blinded so that I know what's going on if I need to modify anything. And this is where stratified randomization comes in. So I got involved with a study with a doctoral student that wanted to look at the effectiveness of improving core power compared to core endurance. And he wanted to do a randomized clinical trial and measure some strength measurements and also some performance measurements. He was interested in throwing velocity because these were all throwing athletes. And so to get an adequate sample size, we had to recruit both softball and baseball players. So obviously there's one stratification where we had males and females, so we had to have an even distribution. And then the second component with that was that we had outfielders and pitchers and infielders, so we had to stratify by position, so we had an even distribution of pitchers in both groups who tend to have really strong arms, and so that was stratified by skills and by sex. So we had a stratified randomization that we had to apply to get even distribution in our 2 intervention approaches. So randomized clinical trial is a study design that's going to assign participants into one of 2 groups traditionally, and as the study is conducted, the only real expected difference is that the intervention is going to be measured to have a positive or a negative or some kind of outcome at the end. And so at the beginning, the groups should look the same. If your randomization works or your stratified blocked randomization works, they should be even looking across at baseline before the intervention starts. Good randomization will wash out any biases or population differences. It's easier to mask than observational studies because you're applying an intervention. You are talking to your participants, say we're going to do this interventional study. They just may not know which intervention group they're going to be in. I remember a study we did a couple years ago where we did knee rehab, and even though one was a hip-based exercise and one was a knee-based exercise, the pamphlets that we gave them all said knee exercise program. And so The patients, even though they were doing leg exercises, some biased toward the hip, some biased toward the knee, didn't necessarily know which group they were working on. Obviously, one of the other advantages with RCTs is you can use a lot of traditional statistical tools and inferential statistics to compare. There's some disadvantages. It can be expensive tracking this, especially for long-term follow-ups. So there's often some expense and time and money with following these patients for longer-term outcomes. There is volunteer bias, so there's some populations that may be more likely to participate in a randomized controlled trial. They don't feel like they're as concerned about their health outcome. They trust that they're going to do that. So there's some biases of people that agree. I'm currently involved with a randomized clinical trial comparing surgery to non-surgery, and it's really hard to get people to agree to be either randomly assigned to surgery or non-surgical intervention for a torn rotator cuff. And certainly if you're doing longer term follow-ups, which most of these kind of studies incorporate, is you can have attrition bias. So people fall out of the study, they stop, they change groups, so there's some disadvantage. The goal of any research is to answer a question in a believable manner. And the validity, especially the internal and external validity, is how truthful did we design our study and sort of identified all the things that we could possibly do to say this is as clear and as clean a study as we can make it. And so the validity or truthfulness of a study is really designed or determined by your study design and your methodological approaches. So you really want to focus on what you want to know and what that outcome is, at the same time not biasing those results by anything that you happen to do inadvertently, and that's certainly this idea of considerations or internal threats. So obviously one of the first important things with an RCT is, was the assignment of patients randomized? Who controlled that? Was everybody blinded to how that was determined? Was there any way that there was undue bias or influence on who went into what group? You want to minimize that as much as you can to say, hey, we did everything in our power to leave our hands off who went into each group. And that can be done very easily a priori with a statistician or with an independent person organizing and helping you organize your group membership, and then putting those in a secure environment. A lot of times people use an opaque envelope so you can't look in and see what's going on with that. So the other thing that helps confirm that you did a good job of randomizing is that your baseline characteristics were equal. I alluded to this before, were the groups treated equally? Did we spend 5 minutes touching both groups of patients? If we're doing one intervention where we're going to do some kind of hands-on intervention, the other one we're doing a sham, we still need to touch that patient for the same amount of time. If we're giving them more exercises or different types of exercises, then we want to try to make sure that we're spending time giving people exercises, but they're quite different, so we see a treatment effect. Doing 2 different quadricep exercises might not build a big enough effect, and so now if you have small effect sizes, you're going to need a lot of subjects. Were all the patients who entered accounted for at the end? And this goes into this concept of intention to treat analysis. So as you analyze this data moving forward, you're looking at those subjects as best you can, whether they continue the care, whether they change group, but in their assigned category. And that's a whole nother statistical approach and interpretation of doing that. But you need to really do a good job of tracking who's getting what and who's falling out of your interventions and for what reasons. I think one of the things when we're doing a lot of hands-on intervention treatments that we can incorporate is getting independent researchers to help us with either objective assessment, or if the intervention isn't too skill driven, using students to provide some of the support or interventions. And here at UK we have these undergraduate research students who are always interested in getting involved with a research project. It helps them as they move into more graduate level work, and so using them to help with either objective measurements or helping blind the researchers in either the treatment or the assessment is really nice. And one of my graduate students at Marshall has done a really good job of that, where he's doing all the testing, but the students are the ones screening the patients. These are all PT students that are screening the patients, so they get to work on their practical skills of who's hurt, who's not, who has to fill out these forms, and then he doesn't ask them those questions. He just does the outcome measurements that we were interested in. And then obviously the other component is, what were the results? How big an effect was it? Was there a significant difference, and was there a clinical meaningful difference? You can find statistical significance, but as Dr. Fleischer talked about, minimally clinically important or minimal detectable change, those are critical values. So these questions all came from the Center of Evidence-Based Medicine critical appraisal tool, and focusing specifically on questions for randomized clinical trials. For those of you who are physical therapists or athletic trainers, this is very similar types of questions that you might have learned about as you went through your program as a score called a Pedro score. And this was the physical therapy folks in Australia created this tool to evaluate a clinical trial. And they asked a series of 11 questions, like what was the eligibility for inclusion, exclusion, how were they randomized, how was it concealed, were the groups equal at baseline, was the subject and the researcher blinded, was the participant blinded, did they have adequate follow-up, what was the statistical analysis, and so on. And you're basically scoring it yes, no, yes, no, yes, no. And so the higher the score, the closer you get to 10, the better the design was. And so this is just a simple way of sort of qualitatively grading a randomized clinical trial that's been used for years and years and years. There's multiple tools out there that can be used for critical appraisal. So outcome tools for interventional studies when blinding is challenging. So if you do an interventional study like we do a lot in therapy with face-to-face care, it's really hard to figure out a way to blind or to minimize the bias. So if I'm doing an intervention study, I'm doing some manual therapy techniques, and then I go and I ask them, how do you feel? What's your pain level? More subjective questions. I might develop a really good relationship and that patient likes me or hates me. That's a little harder to justify instead of using maybe a quantitative sensory test excuse me, or some kind of more objective test. So if you're going to do more face-to-face hands-on interventions, then you want to try to make your outcome as objective as you can. You always want to make your outcome as objective as you can. If you really want to know about function and quality of life, then you might want to consider measuring that immediately, but then again at a later time point. That shows the lasting effect of your intervention several weeks or months down the road. And in orthopedic surgery, they have to look at 1 and 2 year or longer follow-ups to even often get published for some of their surgical interventions. So I just want to go through a few threats. We've talked about assignment or selection, trying to make sure they're equal to baseline. Randomization really helps with that. With those of you working in children or younger populations, as they mature, things change. And so you have to consider maturation which changes. Oh, sorry, I'm looking at the wrong one. This is attrition, so this is fallout. Maturation is the opposite side of that. So losing subjects, if you're dealing with an older population, I know Dr. Butterfield and Dr. DuPont have talked about rats dying because they're already an older animal model, and so there's some issues that they have to account for that they might need to have more to start with at the beginning. So certainly attrition and losing subjects to follow up is really a problem. Maturation is on this phase. That's what I was talking about. So naturally, as you get a little older, if you're following these patients for a period of time, even though you randomize them, their maturation process might be quite different. So sometimes with motor development or motor skills, you might have to take multiple measures over the course of the intervention. History, as time passes, life happens, right? You could have a person go on and break their leg, and that's going to affect their ankle balance. So there's effects that occur outside that study that you can't do anything about it. It's also things that you can control is thinking about when you're starting data collection. When are you enrolling a patient? If I need to see that patient every week or every 2 weeks, I might not want to enroll them right after Thanksgiving when they're going to be gone for the next 2 or 3 weeks on holiday break. I might have a pause and say, okay, we'll start you back up in January if when you come back to school. So consider what's going on in that person's life if you're dealing with different types of patients, or you might be gone. There is a regression to the mean, so outliers tend to start to normalize. Some people go down or go up depending on what you're measuring. So consider that larger scores at the outset of the study tend to gradually work back toward the mean. You might have to make a determination that you have to exclude those. I would do that carefully. A lot of times what I've been suggested to do is to not run or to run the analysis with and without the outlier and see how much it actually changes the data. That's a great question for your statistician as you move forward. So resentment between the two groups. So one thing you have to be careful about is how much do they know? Do patients at the same clinic know they're getting sort of two different treatments? Is there competition between them? This is where blinding is really important, or trying to minimize the subjects communicating with each other about what's going on. You might be doing a clinical trial where you're taking all the patients after a certain surgical intervention. One group's getting some modality or some intervention and another group isn't. So you need to be very clear on how you're going to keep those people separate and not let them start to comparing, because I've been in enough clinics where patients compare and talk about each other's problems and how they've gotten through the rough spots as they go through rehabilitation. So you want to minimize that as best you can. Diffusion of treatments. Participants in two groups communicate with each other, potentially leading to changes. So these might keep the subjects separated as possible. Is a great idea, but might not always be practical, because they start to talk and say, hey, why aren't I getting laser treatment? Or hey, why aren't I getting this additional intervention? And now you start to have attrition because patients want to leave and get a different intervention because somebody had a really good result. Obviously, you need to pick the right instruments. You want a good, reliable, sensitive tool to measure your changes. You need to know those psychometric properties of the measurement tool, and a lot of times with graduate students they want to develop a new tool, so they have to go through reliability and validity testing, and so there's a series of studies that actually have to occur before you can actually start to use it. Most of you in your survey felt very familiar with the procedures of measurement or testing or doing stuff, which is great, but again, you still have to make sure you know that your colleagues or your undergraduate students know what they're doing when they're measuring. So going through several practice trials, going through very standard operating procedures, and getting really familiar with testing is critical as you go through to minimize any kind of internal threats. So the other side of the story is the external validity, or the application. And this really is going to be interpreted by the reader of how does your study look like what my patient is. Was the sample really clean and very narrowly defined, and I don't have any patient that meets that because it took them 5 years to recruit those specific subjects? Or, hey, that's what I see in my clinic. This makes a lot of sense to me. These are the kind of patients I typically see. Setting differences. Elements of the study conducted in a manner different from another clinical setting. So what I mean by that is this something that's really feasible at a typical outpatient occupational therapy or at an inpatient hospital setting, or is this really unique that this really is only appropriate at tertiary hospitals with all of these cool toys and gadgets that makes this really reproducible in those components? Are the treatment interventions feasible at my clinic? So do I have a handheld dynamometer, or do I have a 60,000 isokinetic dynamometer? What might make you choose the isokinetic dynamometer versus a handheld? Even though one might be the gold standard, it might be more clinically applicable to use the $1,000 handheld dynamometer that you can demonstrate good reliability with, because other clinicians might be able to use that. Do I have fancy weight machines, or do I have dumbbells that I'm going to train these people on? Do I have blood flow restriction devices, or I don't have any of those kind of toys? So certainly, will the benefits outweigh the potential harms to my patient? So it's important to identify, is this going to really be beneficial? And you need to report adverse outcomes in the study to identify, hey, two patients had increased knee pain or increased shoulder pain after doing this intervention and dropped out. Because then that's being honest and ethical, but it's also identifying what some potential harms on. Time. The study is conducted during a period of time that's realistic. Most of the time in outpatient physical therapists, you treat for 30 to 45 minutes, maybe an hour if you're lucky. And that's all you have. If your study takes 6 hours to do, that's not a realistic comparison. So you have to take that into consideration. Is this going to be applicable in the real world where I want this to apply? So other couple considerations in intervention studies. Always we do IRB approval for our primary research, or as much as we can, but these, because we're doing an intervention that may or may not be beneficial to our patients, we need to think carefully about these principles of equipoise. This states that the experimental research is really needed, and I think Dr. Fleischer talked about this, that we don't really know which treatment intervention is better. We're going to do this operatively versus non-operatively. Well, there was a cohort study that showed that non-operative management of rotator cuff tears do just very well at 1, 2, 3 years out. So now they've gathered funds, and now they're doing this randomized clinical trial. So there's a rationale that they can clearly show that non-operative care may benefit patients just as well as surgical intervention for a torn rotator cuff. And so that's the kind of idea that you have to be clear in your mind as you're setting this up. Is this something that really needs to be investigated, not just because I want to do it or I think it's a cool idea? Is the source population appropriate? You don't want to use people that might be disadvantaged or coerced into doing this. I think Dr. DuPont talked about, we've got 7 million studies on 19-year-old white males. Are we recruiting more of the same because it's convenient, or is it really helping 55-year-old African American females that might not have the access to the intervention that we're proposing? Obviously, all the IRB components, principles of respect, principles of charity, non-malfeasance, do no harm, all have to be considered as you're going through and developing the protocol and procedures. So respecting individuals that want to participate and understand that not everybody is comfortable being randomized into an intervention. And so that potentially biases, and you want to minimize that as much as you can by explaining what's going on to the subjects, explaining to them what is the uncertainty that we really don't know if operating on you, putting you under anesthesia and operating on you really makes your shoulder feel better a year or two down the road. So we got to make careful decisions about what our control is and how we're going to monitor these adverse events. And Dr. Fleischer talked a lot about data safety monitoring. So when you get to the write-up, you're going to follow the consort statement. It's a really well published and agreed upon document. Most medical journals will use this as you have to identify those components, the key elements in the manuscript. You're going to have your little flow sheet of how you enrolled, included and excluded people, what happened at each observational measurement, and how you followed them up, and who did you do analysis on. This is really pretty easy to build in SmartArt. You can download these versions. When I go to start to set up any kind of study, but certainly a randomized clinical trial, I try to use whatever that checklist is so the student and I can organize, are we addressing all of those components. The statistics we're going to get into in the second half of the semester, but typically these are going to follow some kind of repeated measures analysis as people are traveled. If you have multiple groups and multiple time points, we're typically doing some kind of repeated measures analysis or a linear mixed model. There's advantages to each. If you have people not coming in on a regular basis, sometimes linear mixed model ANOVA is a little bit better to use. T-tests are limited due to the number of observations in groups. Sometimes you can use change scores to overcome those limitations. The other thing that is often reported in intervention studies are numbers needed to treat. This is the expected number of people who would have to receive a treatment to prevent an unfavorable outcome, or oppositely said, it's how many people do you need to treat to get a favorable outcome in one person. So the lower that number is, the better the result is. So if you have a numbers needed to treat at 2 or 3, that's really good. If you have a numbers needed to treat at 40, 50, 60, 100, not as good. So if you apply this sentence, apply an intervention of X to 5 people to prevent a torn ligament, so I have to apply this intervention in 5 people to prevent one person from having a torn ligament, versus I have to apply this intervention in 50 people to prevent one additional person from tearing their ligament or rolling their ankle. So that's how that works, and it's a mathematical calculation of 1 over the absolute value of the absolute risk ratio. So here's the data of a made-up study. We're going to have a good outcome in 20 people and a bad outcome in the experimental group. 20 people had a good outcome, 5 people didn't have a good outcome, whatever that definition is. In the control group, it was 10 versus 15. So the relative risk reduction is the difference in the event rates. So 20 out of 25 versus 10 out of 25. The ratio is calculated, and it's a proportion of the event rate relative to the control or untreated group. And so 0.8 over 0.4. So the relative risk of a positive outcome is 2 times greater if you do the experimental versus the control intervention. The absolute risk reduction is the arithmetic difference between the the event rates in the two groups where you take the control minus the experimental. So 0.4 minus 0.8 equals a negative 0.4. That's why you use the absolute value, so it's 1 over the absolute risk reduction. So the numbers needed to treat in this totally made up table would be 2.5. And I confirmed this in that Java 2x2 table to make sure the math all worked out correctly. But basically this would say that I need to treat 2 to 3 people to prevent a torn ligament, if we go back to that previous example, or if I said it the other way, to achieve a favorable outcome in one person, I need to treat 2 to 3 people. So here's an example of a randomized clinical trial abstract. The purpose of this study was to investigate the effectiveness of 2 exercise interventions, one using eccentric exercises, one using conventional for people with shoulder pain called rotator cuff tendinopathy. They had 36 patients. They enrolled 20 and 16. They were able to keep all of those people through that study. They did a 12-week home exercise program, 2 different treatment approaches, one eccentric, one concentric type of exercise, and they measured them with a functional score called a constant Mertli, and they measured their pain, and they looked at their range of motion and strength at 4 time points: baseline, 6, 12, and 26 weeks. So the results after 26 weeks showed that both groups had a significant increase in constant Mertli and a significant decrease in pain, but there was no difference in the group for any of the evaluated outcome measures. So in conclusion, they found that the 2 exercise programs at the 26-week time point were basically providing the same pain relief. And so there was no benefit of one versus the other. And so their conclusion was, based on these results, clinicians should take into account that performing 2 eccentric exercises equally as performing 6 concentric exercises. So they tried to identify that they wanted to make the interventions equal volume of exercises over the course of that treatment. So things to think about: what were the internal threats that they address? What are the internal threats you would be concerned with regarding this study? What is the external validity? Is it good? Is it bad? Does this apply to patients you might treat? Obviously, if you're not a physical therapist or athletic trainer, you might not see these patients, but you never know. Or an occupational therapist. And then what is the effect size for these 2 interventions? I'm going to stop here. I should definitely be back by now. So I'd like to have an opportunity to walk you through some of the other information related to that. So I'm just going to stop and stop the video and then go from there. If I'm not there by now, I must be having a significantly bad day. Thank you.